It's my pleasure to introduce Dr. Guy Leschziner, who is the consultant neurologist at the Sleep Disorder Center at Guy's. He's also the author of The Nocturnal Brain, Nightmares, Neuroscience, and the Secret World of Sleep. And he's going to let us into some of these secrets this afternoon, talking about what parasomnias tell us about the brain. Guy.
Thanks very much. Hugh's not on commission, by the way. I've been instructed carefully that the videos have not worked on many occasions this morning, so hopefully they will work today. So what I'm going to try and do is I'm going to try and show you some parasomnias and try to show you what they tell us about the normal function of sleep and the dysfunction of sleep and its origins in the brain. But before I do, I'm just going to show you this. So this is something called the Chester Beatty Papyrus, and it is stored in the British Museum. If you ask very nicely, they will pull it out from the stores and you can go into the Sudan and ancient Egypt reading room and inspect this. And the reason why this is fascinating is because this is really the earliest surviving text regarding anything to do with sleep. This is called the Egyptian Dream Book. And in it there are 108 dreams and the interpretation of those dreams and what that interpretation represents. So we've known that something happens in sleep, that it's not just an off state of the brain, really for as long as we've been human. But actually, it's Sigmund Freud who was one of the first really to put dreams as originating from the brain rather than elsewhere, originating from the spirit world, for example. But it was really quite some time after Sigmund Freud, really in the 1950s, that this chap, Eugene Azarinsky, who was doing a PhD with one of the grandfathers of sleep medicine called Nathaniel Kleitman, he was instructed to go away and find out about blinking on the basis of some report that had been written up in Nature about a man who had been seated opposite one of his supervisors who noted that he stopped blinking at the point he fell asleep. And so he was tasked by his PhD supervisor to go and find out as much about blinking as possible and to make a machine that measured blinking. It sounds like Eugene Azarinsky's PhD was as traumatic as my own. And he ended up having to go away many, many times until this project was abandoned. And he was told to add on to an existing project which was looking at baby sleep and movement of babies in sleep. And it was at that point, through the generation of a device to measure eye movement in babies, that he discovered rapid eye movement sleep. So this stage of sleep that we now associate most with dreaming sleep. So REM sleep with periods across the night, much more REM sleep towards the latter half of the night, and when we are woken up from this stage of sleep, that's when we remember dreams of a narrative structure. So we now understand that, of course, that dreaming is not exclusively a REM phenomenon. It also occurs in non-REM sleep, but it's the nature of those dreams that is intrinsically different. In that in REM sleep, those are the dreams that are like a plot evolving in our minds, whereas in non-REM sleep, when people are woken from non-REM sleep, their dreams are much more simplistic. They often are composed of visual imagery, spiders, animals, things coming down off the walls, those kinds of things. So what I'm going to try and show you is that, well, we are starting to know, and our knowledge has increased massively over the last 2 decades or so, that sleep is of the brain and it's largely for the brain. But what we are now beginning to appreciate is that many sleep disorders result from lesions of the brain. And vice versa, if you lesion sleep, we begin to understand what implications that has for the brain as well. So there are a range of sleep disorders that are not intrinsically neurological, like, for example, sleep apnea, which really tell us what sleep is doing for the brain as well. But when we're talking about lesions of the brain, sometimes these are macroscopic. Sometimes these are related to very clear abnormalities that we can see on an MRI scan. But actually, for the most part, they're either microscopic, or they're functional, or they're transient. And I'm going to go through some of these now. But before I do, I'm going to show you a really seminal piece of medical literature. This is from 1950. And I'm not joking about this, actually. Let me see if I can get this working now. So Cinderella, Disney, 1950. And then this from the same film, once again.
Bruno! Dreaming again. Chasing Lucifer? Catch him this time? That's bad.
So, you know, once again, I stress that this is 1950. This is about 5 years or so before REM sleep was really described, and about 25 to 30 years before this condition, REM sleep behavior disorder, so acting out dreams in REM sleep, was described, was formally recognized as a human condition. So either Disney was an amazing neurologist or a very keen observer of human nature. So REM sleep behavior disorder, so we associate REM sleep with muscle atonia. Every single muscle in our bodies is paralyzed. The only muscles that carry on demonstrating some tone are certain external sphincters, the muscles of breathing, and actually it's really largely the diaphragm. Even the accessory muscles of respiration develop atonia, and the muscles that move our eyes, hence the term rapid eye movement disorder. But what happens in REM sleep behavior disorder is that people are acting out their dreams. So clearly something is going wrong in terms of the generation of that muscle atonia. And this is a really good illustration, sorry for those of you who are sitting on that side. What you can see here is this is the EMG during an epoch of REM sleep, and there is complete muscle atonia. This is what it should look like throughout. But actually in patients with REM sleep behavior disorder, what you see is often sustained or irregular muscle activity where there should be none. This is not a particularly rare condition in neurological terms. It affects about 1% of the adult population. In keeping with REM sleep being predominantly in the latter half of the night, these behaviours tend to occur within the latter half of the night. It's very rare for individuals to exhibit this kind of thing within the first hour or so, because it's quite abnormal to go into REM sleep within the first hour of sleep onset. And individuals with REM sleep behavior disorder really exhibit a variety of behaviours, but they're rather simplistic behaviours. They're often lashing out, crying, swearing, screaming, or shouting. During these events, their eyes are closed, the speech is usually unintelligible, and patients do not leave the bed. Now, this is a really very useful clinical indicator that what you're dealing with is REM sleep behavior disorder, because the only situation in which patients with REM sleep behavior disorder leave the bed is usually when they've had an awakening and they're slightly confused. So they'll jump out of bed but will wake up very quickly, which is a real discriminator in terms of from some of the other parasomnias that we see. And individuals in REM sleep behavior disorder generally have semi-purposeful behavior, but they don't interact in a meaningful way. So they will not have full-blown conversations with their bed partner. They will not open and close drawers. They will not start fumbling with things around the bed. Often the behaviors that they exhibit are lashing out, fighting, because what they're dreaming of is fighting off a tiger or having an argument with somebody. So they'll often lash out or punch out. If woken, they will frequently have dream recall that's appropriate to the actions that are described. So they will remember the fact that they've been fighting or having an argument. And these sorts of events can occur every night, sometimes several times a night. And one of the biggest issues is injuries to self or to the bed partner, because they'll often lash out. They will hit the bedside cabinet, the wall next to the bed, or occasionally even their bed partner. So it can result in serious injury, and indeed has been featured in some medico-legal cases. So just to illustrate what that looks like, so this is a chap who is attached to a CPAP mask because he's got sleep apnea. don't know how visible that was. That bedside cabinet probably weighs about 70 kilos and he almost topples it. So, really quite forceful actions. Watch this chap's legs. And you can imagine that if you're on the receiving end of that kick, you're not going to be very happy in the middle of the night. The dreams that individuals act out are not always violent. So this next case is somebody who, just watch his hand. And this chap was dreaming of a gunfight in the OK Corral. There have been beautiful descriptions from one of the Parisian groups of individuals who are lying in bed singing, and when they are woken, they remember being in the shower and singing in the shower. Or there's one beautiful description of a French case of somebody sitting up in bed, flapping his wings and quacking and making siren noises. And when woken up, he dreamt that he was a police duck chasing a burglar. So they're not invariably violent, but often the violent ones are why they come and see us in the first place. So what do we think is going on here? Well, in the bottom end of the medulla, we have a number of nuclei that are switched on during REM sleep, and this particular nucleus has glycinergic and GABAergic projections, inhibitory projections to the spinal interneurons, and this nucleus is switched on during REM sleep, and hence the REM muscle atonia that we see. And presumably, something is going on within this area of the brain that results in the loss of those normal pathways. We used to consider REM sleep behaviour disorder as idiopathic, having no known associations. But what we've learned over recent years is that this is a very, very strong marker of neurodegenerative disorders, specifically alpha-synucleinopathies, so Parkinson's disease, dementia with Lewy bodies, and MSA. But the strength of that association has really only become apparent over the last 10 years or so. So this is a paper from a Barcelona group where they took a large number of individuals, I think it was somewhere in the order of about 150 individuals with REM sleep behaviour disorder, and they followed them up for 14 years. At the end of those 14 years, 91% of those individuals had converted to a neurodegenerative disorder, mainly, or the most common of which was dementia with Lewy bodies and then Parkinson's disease secondly. With the median time from symptom onset to diagnosis about 11 years. Now, there have been case reports of individuals developing REM sleep behaviour disorder some 30 or even 40 years before the development of Parkinson's disease, but certainly years or decades before they often exhibit REM sleep behaviour disorder. And actually, subsequent studies have all demonstrated that rates of conversion are somewhere upwards of about 70% by about 12 years. So this is a fairly consistent finding. And when one looks at the pathophysiology of these alpha-synucleinopathies, it's easy to understand why patients with these conditions may develop REM sleep behaviour disorder many years before they develop the motor symptoms of Parkinson's disease or the cognitive symptoms of dementia with Lewy bodies, in that the alpha-synuclein deposition often occurs within the olfactory bulb, hence anosmia as being a part of the prodrome of some of these conditions, and also in the brainstem itself. And it seems that alpha-synuclein deposition within the brainstem results in disruption of these circuits within the lower brainstem that are responsible for mediating REM atonia. So, does isolated REM sleep behaviour disorder really exist? Well, we used to think that that's the case, and certainly there are some individuals who have a very strong family history of REM sleep behaviour disorder. They usually present with RBD at an early age. The other thing that we associate RBD with is narcolepsy. So individuals with narcolepsy very frequently report REM sleep behavior disorder. But actually, when one looks at the slightly older cohort of patients with RBD, we see a whole range of clues that actually this is not purely REM sleep behavior disorder, that actually it is part of the prodrome of a neurodegenerative condition. They have lots of autonomic abnormalities. If one performs skin biopsies to look at alpha-synuclein deposition in the skin, they have much higher rates of alpha-synuclein on those biopsies, and they often exhibit some of the other prodromal features of Parkinson's disease, such as constipation, anosmia, very subtle Parkinsonian signs, and an abnormal DAT scan. These patients often exhibit very subtle cognitive symptoms and signs. And actually, we're now beginning to understand that the presence of RBD in Parkinson's disease, once Parkinson's disease has been established, is also quite a useful marker of the likelihood of cognitive decline over the next few years. So in one study, they demonstrated that the presence of RBD in Parkinson's disease is associated with a risk of dementia of about 48% over 4 years. They found that in those without RBD over 4 years, none of them developed dementia. Now, I suspect 0 is always questionable, but certainly implies that there's a very strong correlation with RBD and cognitive decline, and that actually RBD may be a marker of a particular subphenotype that may allow us to have some prediction as to the course of Parkinson's disease or their associated condition. So really suggesting that RBD is a prodromal alpha-synucleinopathy, but also opening the gate for potentially intervening in these patients. So if and when we have good disease-modifying drugs in these kinds of disorders, the time to start these disease-modifying drugs would be many years before the development of motor symptoms or cognitive symptoms. And if we've got an early warning feature, particularly if you have RBD associated with a whole range of other features that put you at very high risk of converting over the next few years, then these patients make a very good target for these kinds of drugs. So I'm going to move on now. This is a patient of mine who...
There's two sides to it. The narcolepsy bit is I'm chronically tired, and the cataplexy, it can manifest itself in me falling to the floor if I experience a strong emotion like laughing. It's any event that I feel is funny, so it's an emotional connection. The first event that ever happened was trying to put the children to bed. I fell to the floor and wasn't able to get up. The kids were laughing. They thought I was just play acting, and I was just lying there. I could hear them and I could see them, but I was unable to speak or move. It was bizarre, and just didn't know what it was.
So obviously he's describing narcolepsy with cataplexy, or as we now term it, narcolepsy type 1. So narcolepsy is not a rare condition in neurological terms. It affects about 1 in 2,000 of the population. There is a significant range of incidence and prevalence in different parts of the world. It's one of the few conditions that Jews have less of, so I'm pretty sure that I'm hopefully not going to get narcolepsy. It affects males and females equally, and one of the features of narcolepsy is that patients with narcolepsy have unstable sleep. They have an unstable switch between wakefulness and sleep, but also REM sleep and non-REM sleep. And it's that instability of that switch that explains many of the symptoms that individuals with narcolepsy get. So they get the excessive daytime sleepiness because they're flicking in and out of sleep during the day. They also, by the way, have very fragmented nighttime sleep. So sometimes, particularly if people don't have cataplexy, it can be rather a difficult diagnosis to make because the daytime sleepiness is often blamed on their poor nighttime sleep, whereas that might actually be narcolepsy. They also experience hypnagogic hallucinations, so these are hallucinations that are typically visual but can be auditory and can be sensory at the point of drifting off to sleep or waking up. And I'll explain what we think is going on in these cases. They experience sleep paralysis because of that instability between wake and REM. The muscle atonia that I described in the first condition in REM sleep behavior disorder will often persist into wakefulness, and they will experience that paralysis despite feeling fully awake. And they will also experience cataplexy, which is this sudden loss of muscle tone associated with, usually associated with strong emotion, particularly positive emotion. So until recently, the cause of this condition was largely unknown. Von Economo, who, as you'll all know, described encephalitis lethargica after World War I, was struck by the fact that there were certain parallels between encephalitis lethargica and narcolepsy. But in narcolepsy, the brains of sufferers was always normal. And he speculated at that point that damage to the brain in narcolepsy is probably in a similar area, but it's not visible to the naked eye. And he was actually quite prescient. So our understanding of what causes narcolepsy really came from Skeeter and his colleagues.
Skeeter is a small dog with a very big problem. No matter how much he struggles to stay awake, he can't. For this 11-pound toy poodle, almost every moment is a disturbing, losing battle with the urge to sleep.
Sorry. So actually what he's exhibiting there is not the urge to sleep. What he's exhibiting there is cataplexy. So he's very happy to see his owner. He wants to play with his owner, and that positive emotion results in cataplexy, the sudden loss of muscle tone whereby he can't get up. And later on in the video, there's a rather tragic, heartbreaking scene of him trying to jump onto the sofa to greet his owner and then flopping on the floor before he gets onto the sofa. So in the 70s, actually in the late 60s and the 70s, Stanford set up a breeding program because narcolepsy with cataplexy had been identified in a variety of breeds of dogs. And they set up a breeding program to try and get a very pure cohort of dogs with narcolepsy. By 1999, so this was a huge amount of work, they had identified that in the canine familial form, it seemed to be related to mutations in a particular gene, which at that time was unknown, the function of which was unknown. And it was almost simultaneously that this substance hypocretin, otherwise known as orexin, was found in humans. And so it was proposed that actually it was some sort of genetic problem in the genes that regulate hypocretin transmission that underlie narcolepsy in humans. But actually, at that time, and in fact subsequently, only one patient with a hypocretin gene receptor mutation has ever been identified. So clearly implicating that neurotransmission system, but not really giving us the answer. But when one looks at the brains of individuals with narcolepsy type 1, narcolepsy with cataplexy, what one sees, so this is the lateral hypothalamus stained for hypocretin, and one can see that the hypocretin-producing neurons have been entirely eliminated within the brains of individuals with narcolepsy type 1. And indeed, when one looks at the CSF and analyses that for hypocretin levels, it's almost all patients with narcolepsy type 1 have low or absent levels of hypocretin in their CSF. So what does this nucleus do? Well, without going through all the nuclei, these are the hypocretin producing neurons in the lateral hypothalamus that project very widely, both to the forebrain, but also down to the midbrain and beyond. And they are responsible for, as we discussed, switching on or preventing sleep. So they promote wakefulness, but they also promote non-REM sleep when we are asleep. And it's when that nucleus is damaged that it gives rise to all these symptoms. But what causes this loss? Well, we know that narcolepsy is one of the conditions that is most strongly associated with an HLA type, and as with other HLA-associated conditions, that implicates the immune system. In GWAS studies, a gene called T-cell receptor alpha has been strongly associated with the development of narcolepsy. There have been epidemiological studies that show that seasonal fluctuations of onset correlate with the incidence of upper respiratory tract infections. And of course, one of the key areas that has been very helpful is the epidemic of narcolepsy that was associated with the pandemic swine flu program. So we had a massive spike of young people, particularly with narcolepsy, after the vaccination program in 2009 and 2010. And so and in fact, subsequently, what has been demonstrated is that there are very clear alterations in T cell populations in those with narcolepsy. It seems that swine flu or the swine flu vaccine has an epitope which is recognized that looks structurally very similar to hypocretin and precipitates a dramatic immune response that then damages the hypocretin-producing neurons. So this is what normal sleep looks like. I don't know whether you can see that at the back, but I've shown you a hypnogram previously. This is what the sleep of narcolepsy looks like in over a 24-hour period, and you can see frequent REM onset periods. So as I said right at the start, it's not normal for people to go into REM sleep for at least an hour or so after sleep onset, whereas individuals with narcolepsy will frequently go directly from wake into REM sleep. And so we think that actually the hallucinations that people experience at sleep onset or sleep offset are the continuation of REM mentation, of dream mentation or dream imagery into wakefulness, and a lot of these symptoms can be put down to incomplete dissociation of these sleep states. A sort of wakeful dreaming, if you like. But why is it that patients with sleep paralysis have very characteristic hallucinations? So the typical hallucinations of individuals who experience them at the point that they are having sleep paralysis are either incubus or succubus hallucinations, so demons attacking them, pinning them down, interfering with them sexually in the middle of the night, sometimes intruder hallucinations, so a figure standing at the end of the bed, peering over them, or occasionally floating above themselves, so an out-of-body experience. They're looking down on themselves sleeping. And we don't know why that's the case, but V.S. Ramachandran, who I'm sure you'll all have heard of, really speculates that this is as a result of confusion with the superior parietal lobule. So this is where our sense of body and sense of where we are in space resides. And when one is paralyzed during REM sleep, during sleep paralysis in full wakefulness, this results in confusion within the superior parietal lobule and results in the projection of our own sense of self, a humanoid form outside ourselves. An interesting thought, one of the features that is very clear from the literature is that for those individuals who have a positive dreaming experience, they're much more likely to have out-of-body experiences rather than incubus or intruder hallucinations. So it seems that that might be modulated by our own view or our own association with dreaming. And I'm not going to go through the reasons for why these hallucinations have lots of sexual connotations, but go and have a look at his papers. They're very interesting. And what about cataplexy? Well, we really don't know why cataplexy occurs in these individuals. But actually, when one looks at other species, there is this phenomenon of tonic immobility. So these are animal species that, in response to threat, they play dead, essentially. They lose muscle tone, they go floppy. And one hypothesis is that laughter, which by some people has been proposed as a evolutionary mechanism for dealing with threat, might precipitate or might trigger off these vestigial pathways in individuals in narcolepsy, because one of the functions of hypocretin may be to inhibit those pathways. Once again, a very interesting hypothesis, very difficult to prove. And one of the other features of narcolepsy is that of lucid dreaming, which of course affects many people without narcolepsy as well. And certainly when I was at medical school, this was very much viewed as with a significant degree of cynicism, but it describes a degree of awareness or a degree of consciousness present during REM sleeping with the ability to guide or control dreams, and it implies the coexistence of REM and wake. So what evidence do we have that this is a very real entity? Well, this is a really rather fascinating study where they got 6 lucid dreamers into a functional scanner, and initially they just got them to lie in the scanner, to open and close one hand, to move their eyes left and right 3 times as a signal, and then to open and close the other hand. And what they clearly demonstrated, unsurprisingly, is that you activate the hand motor areas of the contralateral side when you do that appropriately there. Then they got them to lie in the scanner and simply to imagine that they were opening and closing their hands. And sure enough, once again, there was activation of the appropriate motor areas, less so because there was no movement involved. Then they got them to go into the scanner and fall asleep, and asked them to, when they were lucid dreaming, to signal the fact that they were lucid dreaming by moving their eyes left and right 3 times, and then to do the same thing. So to dream that they were opening and closing their hand for 10 seconds, to signal with their eyes, and then to dream that they were opening and closing their contralateral hand. And sure enough, what you see is, once again, it doesn't show up very well on here, a similar activation of those motor areas. So clearly demonstrating a degree of awareness, a degree of consciousness during lucid dreaming. And in fact, subsequent studies have shown that lucid dreaming is associated with certain features that are consistent with wakefulness. So a higher power in the gamma frequency, especially in the frontal and frontolateral regions. The coherence patterns in lucid dreaming are much more similar to wake than they are to REM sleep. And it really implies what we have always thought, that lucid dreaming seems to be a hybrid state of REM and wakefulness. And in a fascinating follow-up study, the same investigators actually tried to mediate or tried to precipitate lucid dreaming using alternating current stimulation, transcranial AC stimulation on the frontal lobes by stimulating them with a similar sort of frequency to that gamma power that had been demonstrated in previous studies. And they demonstrated that using specific frequencies, so 25 to 40 hertz, they could actually increase the lucidity of dreaming. So I think this perhaps tells us some interesting things about consciousness. I'm not sure what those interesting things are. I'll leave that for you to decide. Some other studies have demonstrated some changes in functional connectivity in individuals who are lucid dreamers. So what about this? Well, this is somebody who looks like he's awake, suddenly woken up out of sleep. But actually the EEG demonstrates that he remains in slow wave sleep, in very deep sleep, in non-REM sleep. And this is this is a child now who...
Please! No, Mum! No! Mum, stop! Mum, please stop me! If I press it, I'm gonna die! No, you're not. No, yes I am! No, you're not.
So that child is also in slow wave sleep. So you can see that the actions of that child are very, very different from what I described with regard to REM sleep behaviour disorder. There's interaction with his mother, interaction with his surroundings. He appears to be awake, making sense, perhaps inappropriately, but making sense. It looks to all intents and purposes awake, whilst his EEG demonstrates ongoing slow wave activity. So these are non-REM parasomnias, a spectrum of behaviours that arise typically from very deep sleep, and they range in terms of the behaviour that's exhibited from sleep talking to confusional arousal. So this is what I demonstrated to you in that first event of people suddenly sitting up in bed, perhaps looking a bit confused before either going back to sleep or waking up fully. Sleep terrors or night terrors, as I showed you in that child, but also some bizarre behaviours like sleep eating, sexsomnias. I've got individuals who have driven their car in their sleep, ridden a motorbike in their sleep, a whole range of other things. So these are really quite complex behaviours with eyes typically open, interaction with the environment. There's typically amnesia for these events, although actually we're now beginning to appreciate that some retained recall is not at all the exception, and many patients will have some retained awareness for these events, particularly if there's a very strong emotional context to them. So what does this tell us about the brain? Well, this is a really another remarkable study where they actually managed to get a sleepwalking patient into a SPECT scanner. So that's the most remarkable thing. The other remarkable thing is that what they demonstrated in this one individual is that actually during this event, there is significant activation of areas of the limbic system and the cerebellum, much more looking like wake, whereas actually particularly the frontal lobes exhibit reduced behaviour, a reduced activity that is consistent with slow wave sleep. So implying that there is some sort of, once again, disconnection or dissociation between different parts of the brain and the sleep states that they exist in. And in fact, electrical studies, EEG studies with scalp electrodes, but mainly with intracranial electrodes, have also demonstrated this to be the case. So the really consistent features are that from a metabolic and from an EEG perspective, the frontal lobes in particular appear to be to remain in deep sleep. The limbic system very commonly seems to be awake, and the other area that often remains in slow wave sleep appears to be the hippocampus, and that may well explain why amnesia is a common feature of these events. So it's important to stress that sleep is not a universal brain state. Now, we've been aware of that for quite some time. There are many species, particularly aquatic mammals and certain birds, who are able to sleep with one half of the brain at a time, unihemispheric sleep. So within fairly complex animals, we are aware of the fact that not the whole brain needs to be asleep at the same time. And it seems that actually this is what's happening in patients who are exhibiting these non-REM parasomnias, which actually raises some interesting questions, because do humans exhibit unihemispheric sleep? Well, actually, we've never been able to demonstrate that, but an interesting study done a year or two ago has actually demonstrated that when you take somebody into a strange environment, i.e. a sleep lab, on the first night, there is a reduction in the depth of slow wave sleep power in the dominant hemisphere, which then normalizes the second night, implying that we at least have the ability to differentially regulate sleep in the different hemispheres. And actually, this issue of local sleep, as we call it, perhaps has some implications for our waking selves, in that when one looks at rodent models, what one sees in rodents that have been kept awake for prolonged periods of time is that there are small networks of neurons that seem to fall silent. They do that anyway, even when the rats are not sleep deprived. But the more sleep deprived they are, the longer those periods of silence persist, suggesting that actually rodents at least have the ability to exhibit local sleep, where very small areas of the cortex are constantly dipping in and out of sleep, and the more sleep deprived we are, the more likely, the more prolonged, the more extensive these areas of local sleep are. And there are some human studies that suggest that this similar sort of thing might be happening. How are we doing for time? Okay. I was going to... Do we want to stop for questions? Because no.
Well, we've got time, so...
Okay, so it's important to recognise that not all parasomnias are indeed parasomnias. So sometimes these can be very, very difficult to distinguish, because seizures, particularly frontal lobe seizures, can often generate some really rather complex and bizarre behaviours at night. And in fact, seizures of any origin can sometimes precipitate parasomnias by causing epileptic arousals, usually in stage 2 sleep rather than stage 3 sleep. Sorry, I was talking while that video was going on. So this was somebody who had a frontal lobe seizure that resulted in what looks like a sleep terror. This is another individual who was referred in with difficult to treat screaming episodes at night that were said to be sleep terrors. But what you can see here, it's quite difficult on this screen because it's very small. So with each of these events where he suddenly wakes up, he performs exactly the same movement with his right hand. The hand comes up to a very stereotyped onset. And actually what this turned out to be was frontal lobe seizures. In some of them they are more dramatic than that, rather than non-REM parasomnias. And actually we stopped completely with Kepler. Sometimes these can be very, very bizarre indeed. So this is somebody who was diagnosed with non-epileptic seizures for many, many years. And you can probably see why once you see the video, because she looks like an extra from The Exorcist. But actually, this is a rather complex frontal lobe seizure, and we recorded several of these very stereotyped as well. And one of the difficulties with frontal lobe epilepsy is that these have a particular predilection for sleep. There are many patients that I see who have never had a daytime seizure, only have exclusively nocturnal seizures. These are typically occurring in stage 1 and stage 2 sleep rather than stage 3 sleep. Stage 3 sleep seems to be protective, less protective than REM sleep, but certainly fairly protective against having seizures. And they often have these seizures at the transition between different sleep stages. They can be very difficult to diagnose. This is somebody who we wrote up a few years ago who presented with recurrent nocturnal choking attacks that were said to be psychogenic, and she was treated for 30 years with antipsychotics. But actually what the PET scan demonstrates is this area of hypometabolism in the insula, which was responsible for choking attacks. Insular seizures, like frontal lobe seizures, often have normal EEG during the events because, as with frontal lobe seizures, the ictal origin is very deep and can be very difficult to pick up on the EEG, or can sometimes be obscured by artifact. So, I hope I've shown you that sleep medicine is of the brain and for the brain. But more importantly, the study of these disorders really gives us some insights into normal sleep and normal brain function, as well as telling us about these conditions per se. Thank you.
Thank you. Fascinating talk, thanks. This idea that cataplexy might have some link to playing dead in other species. I mean, people have also written about the sort of, if you like, conceptual parallel between playing dead and catatonic stupor. I'm not aware of any, despite the similarity in name, I'm not aware of any association between catatonia and cataplexy. But
yeah, I mean, my understanding of catatonia, and I hark back to my days as a medical registrar and being called onto psychiatric wards in Chase Farm or wherever it was, is that, you know, these patients exhibit tone, you know, whereas actually in cataplexy there is a complete loss of muscle tone. In fact, what cataplexy most looks like is negative myoclonus. So typically patients who exhibit cataplectic events, it's actually very rare for patients with cataplexy to injure themselves because they kind of lose tone very briefly initially, and then that escalates. So they often get a significant warning and can lower themselves to the ground. The other thing about cataplexy is we always imagine cataplexy as being, you know, collapses to the ground. Actually, for many patients, cataplexy is very segmental. So it's typically, you know, a little bit of nodding with laughter, and that's, you know, almost like a negative myoclonus of the head. A little bit of facial slackening, so when they laugh, their face will kind of wobble a little bit, and actually in children it can actually look like positive myoclonus, the inverse. Whereas, you know, catatonia is totally different.
Thank you. Can we diagnose RBD when patients are on antidepressants?
It's a very good question. I think the answer to that is we don't know yet. I think the general feeling is that antidepressants are likely to unmask RBD in individuals who are going to develop it subsequently, but that's not yet been definitively proved.
Thank you. That's a brilliant talk. I guess it's a question about the way sleep medicine has gone. Referring to your clinic and things, there's a lot of respiratory physicians, and I guess sleep has been lost largely from psychiatry and neuropsychiatry. Do you think it's time it came back into the fold?
Well, we're doing that already, actually. So when I started at Guy's, it was four respiratory physicians. I think, Hugh, you were there one day a week, and I was the first neurologist to join that team. We now have 4 respiratory physicians, 3 neurologists, 2 psychiatrists, a neuropsychiatrist, a psychologist, another psychologist about to start. So we are definitely wrestling sleep back from the respiratory physicians. So, yeah,
brilliant. That's
I'm with you.
That was fantastic. Thanks very much. I was wondering if individuals with cataplexy, do they tend to deliberately try and avoid strong positive emotion or laughing? And do you ever recommend that they do that?
Well, I don't recommend it because I think that the answer to that is yes. They often say, they come in and they say, oh, well, I'm dealing with it. And you say, well, how are you dealing with it? And they say, well, if I'm getting to the point of strong emotion, I tend to pull myself back a little bit, which I think is terribly sad because, strong emotion is part of life and part of the enjoyment of life. And I would argue that actually people who are doing that are undertreated.
I have a somewhat sceptical view of sexsomnia.
Oh dear, Mike, okay.
I know you had a case that persuaded you.
Yes.
Can you talk about differentiating the real sexsomnia cases from the...
Do you want to come and give this talk, Mike?
Pardon?
Do you want to come and give this talk, Mike? That's a separate talk entirely.
No, I'd like
Okay, so I think one is you are absolutely right to view these cases with a large degree of scepticism, and I think there's no way to be sure that an event that is being prosecuted was a sexsomnia or a non-REM parasomnia unless you had EEG electrodes attached to the scalp at the time. So your view has to be based upon certain factors. So was there pre-planning? Is there a preceding history of these kinds of events? Are there features on the sleep study that are supportive of a non-REM parasomnia? Those kinds of things. Was there, just like all the other just like standard forensic practice in the non-REM parasomnias, did the person negotiate a complex novel environment in order to find their victim? So there's a whole range of features that would push you in one direction rather than the other. The case I think that you're talking about, there remain some unanswered questions, but what is quite definitive is on every single sleep study that we've done, we've demonstrated really quite dramatic and prolonged episodes of an arousal with persisting delta sleep, despite behavioural correlates for a very long period of time. Very unusual to actually find that in individuals. Most of the time when you do a sleep study on somebody who's got a non-REM parasomnia, you don't actually capture anything. So clearly, very strong predisposition. His current partner says that he exhibits sexsomnia on a regular basis. There was a preceding history of non-REM parasomnias, not sexsomnia. So I think there are almost certainly some very genuine cases out there. I suspect the majority are not, but that's why I don't do medico-legal work. I'll leave that to you.
Thanks for this very interesting talk. It's interesting to talk about sleep post-lunch in a conference. So I'm just curious to know, what do you offer in terms of treatment for these patients who suffer from parasomnias?
So it depends which parasomnia you're talking about, because we know that non-REM parasomnias are... So a lot of it is about supportive management, making sure that they are not at risk and their partners are not at risk. For the non-REM parasomnias, we know that for particular individuals, poor sleep hygiene, poor quality sleep, sleep deprivation, daytime stress can make these events more like alcohol as well. So it's about lifestyle changes, managing stress, sometimes cognitive behavioural therapy for insomnia, or we're modifying it with Hugh to cover parasomnias as well. In terms of medications, the evidence base is rather poor. There is some evidence for the use of clonazepam in these individuals, but we obviously don't like to use that long term, and we try and reserve that for when the risk of these kinds of behaviours is highest. There is some evidence for paroxetine, although I don't like to use paroxetine because they have terrible problems getting off paroxetine subsequently if they want to. But certainly, anecdotally, a lot of the tricyclics, a lot of the SSRIs, and actually we've recently published a paper when we looked at, we had a cohort of 500 odd non-REM parasomnia patients, which demonstrated that actually melatonin is as effective as any of the existing treatments in dealing with these non-REM parasomnias. And melatonin, of course, is far less toxic as far as we know than any of the other drugs. For RBD, really that is not particularly influenced by lifestyle issues, and then it's a case of treating with, typically, once again, first-line treatment. Melatonin has now been used for quite some time in RBD, clonazepam, and then there are some more experimental treatments that we occasionally use, including, I think I've started one patient with very violent RBD on sodium oxybate to good effect, but that's, one patient.
So I think, unfortunately, we've run out of time. So it's time for the tea break. I'm sure Guy will be around to answer any individual questions during that break. And so thank you again, Guy.